All right, now we're going to talk about synovial joints and levers, section 6 of chapter 9 for skeletal articulations. You should be able, after going through this section, define a lever, distinguish between the effort arm and the resistance arm in a lever, and compare and contrast the three types of levers in the human body. Now, even though this is a very short section, it's still a crucial section and probably deserves even more time, but even though it's technically kind of a combination of physics as it relates to biology, but it plays a major role in understanding our basic joint actions and how it affects joints when we're moving load or moving in general. Now, a lever is simply an elongated rigid object. It rotates around a fixed point around a fulcrum. The fulcrum technically is the joint. We're talking about motion here. Effort is what is applied to a given point or place in location in space. From the standpoint of effort, the body, the muscle always supplies the effort. Okay? Muscle always supplies effort. We'll revisit this again, of course, we get to muscles here shortly as well. Resistance is at some other point. If you're just moving your arm, then the resistance is the weight of the arm related to gravity. Effort is the muscle that moves at the shoulder. If you're trying to raise your shoulder into abduction out to your side of the frontal plane, then be talking about your middle head or lateral head of your deltoid that was actually doing the work, and the fulcrum being that shoulder joint. Movement occurs if effort exceeds resistance. If resistance exceeds effort, then there's no movement. The effort arm is basically the distance from the fulcrum, the joint, to wherever the effort attachment point is, which technically is the insertion point of the muscle. Okay? And the resistance arm is basically the part of the lever from the fulcrum to the point of the resistance, so wherever the load is applied. Okay? The end of the load, if it's like your arm, or if there's a dumbbell in your hand, that would be the resistance, and the distance from the resistance to the joint is the resistance arm, from the effort or muscular attachment to the joint is the effort arm. Now, first class lever. Pretty much one of the only times you're going to see it. There aren't many first class levers. There are very few, in fact. Is basically occurring at the cervical spine, where the fulcrum is the axis of the cervical spine, the joint of the spine. The resistance is gravity pulling the head downward, and the muscles of the neck here on the posterior side of the spine region there are pulling into extension or hyperextension in this case, whereas gravity is trying to pull down. It's a first class lever because the resistance is on the opposite side of the effort, okay, with the axis or fulcrum in the middle. Okay. I really like to call it whereby it's effort is still E is effort for the muscle. Fulcrum is really A for axis. So really what you really have is E and an A and an R. You have an ear. Okay. Effort, then axis and resistance. That's what makes it a first class lever technically. Okay. Second class lever. The only time you're going to see it, it's extremely rare. This is pretty much the only time it's going to be seen, is going to be involved in basically plantar flexion. The axis or fulcrum is basically at the ball of the foot here essentially, okay? And what's basically occurring here, you kind of go up on your tiptoes, going up on the very edge of your toes there. Basically that action going up into a calf raise, some would call it, is a second class lever action, whereby the axis, of course, is the bones of the toes right down here, and the resistance is gravity pulling down. The effort is the calf muscles, technically the soleus and the gastrocnemius, doing the work here, like a wheelbarrow. And it's a second class lever because the resistance is in the middle. It's between the effort and the fulcrum. When the fulcrum is in the middle, it's a first class lever. When the resistance is in the middle, it's a second class lever. And third class lever, the effort's going to be in the middle. Okay? Where in this case, the axis, like your elbow in performing arm flexion, or I should say elbow flexion, and the same would be true for elbow extension with the triceps as well. Would also be a third class lever the other direction, going into extension versus flexion, still a third class lever from the standpoint that there's the axis, muscular attachment, it crosses just past that axis point. That's why that right from that point there to the axis, that's the effort arm. And the resistance arm is going to be the distance from the axis to where the load is applied, way out here. Because the resistance is so much farther away than the effort arm, it has what we call a mechanical advantage. We'll bring that back when we talk more about motion later on to some extent. But that in this case, biceps in general, one of the reasons why arm curls are so difficult when done correctly is because the load is much farther away than the muscular attachment is to the radius, in this case, on the biceps brachii, relative to the elbow. So consequently, when you're talking about moving load, you're probably exerting 8+ times more than you would think. In other words, a 20-pound dumbbell is kind of like lifting 160 pounds. Okay, or not 160, about 160. That's how heavy it is. Okay, that's why it's so much more difficult to do a good arm curl, because it's a third class lever. And we can't do anything about that. Third-class levers are what they are, just like second-class levers are what they are, and first-class levers are what they are. So you should know the difference between the effort arm and the resistance arm in a lever. How does the position of the fulcrum, the resistance, and the effort vary, making it a first-class, second-class, third-class lever? Now we're talking about features and anatomy of selected joints. The temporomandibular joint, we're only going to talk about very, very briefly, and the motions of the TMJ. You should also be able to describe 3 individual joints that make up the shoulder articulation. We'll spend more time with that. Explain why the glenohumeral joint is relatively unstable. Describe the elbow joint and its motion, and explain why the elbow joint is relatively stable. Also be able to describe the hip joint and its motions, explain how the hip joint is more stable than the glenohumeral joint, describe the knee joint and its motion, name the ligaments that support the knee, and describe the talocrural joint and its motion, the ankle joint. The temporomandibular joint, we're basically talking about the head of the mandible and how it articulates the temporal bone. It's the most mobile joint, or the only mobile joint, we should say, between the bones and the skull. Technically, it's got a loose articular capsule. It has an articular disc. It divides that synovial cavity into 2 chambers. And it provides a fair amount of range of motion there. We're not going to spend too much time on the ligaments right now, but generally speaking, the movements of the temporomandibular joint it's a hinge, it has some gliding and some pivot joint motions. That said, it's a fairly mobile joint. I'm not going to worry about the anatomy here. That'll be spent more time in lab focusing on that. But TMJ disorders, people talk about someone having TMJ, even though technically that's not really, it's with temporomandibular joint. It's like someone saying they have a hamstring. You may have heard that before. You mean a hamstring pull or a hamstring tear? You have TMJ disorder, not just you have TMJ. The most common is due to alteration in the ligaments that secure the joint. There's an articular disc that's forced out of its normal position, and you get a clicking or popping noise heard as the person opens their mouth. And I've actually noticed that if I'm just chewing and turning my head sideways and putting my joint out of alignment there, I've actually noticed it popping. But if it's normally, I wouldn't hear it. That's the exact same thing that you're getting, but normally people are trying to chew normally and they're having that same exact response, possibly pain as well, not just in the joint, but in the paranasal sinuses, the tympanic membrane, oral cavity, the eyes, and the teeth. It can be pretty severe for people who actually have this disorder. Sternoclavicular joint for the shoulder, we spend more time on that. It's a saddle joint, the SC joint is, formed by the manubrium and the sternal end of the clavicle. Okay, the manubrium is basically at the sternum, and the sternal end of the clavicle, of course, is their connection point there. It's an articular disc that's a partitions the joint into 2 parts, forming 2 synovial cavities here. It can perform elevation, depression, and circumduction, that SC joint to some extent. And stability is provided by the fibers and ligaments. It makes the joint very stable, and it's difficult to dislocate, although it is possible to do, and people have done it. You have a sternoclavicular ligament right here. Here's your clavicle coming across here, the articular disc here, and then our articular capsule. The manubrium of the sternum here, the body of the sternum right down here. If you're looking at this from the anterior, the costal cartilage here. Here's a costoclavicular ligament, and this would be the first rib, technically the uppermost rib, and second rib here. Okay. You will not have to do this on a test for lecture, but you will likely see this in lab. The acromioclavicular joint, second of 3 primary joints for the shoulder, is a plain joint. It's formed from the acromion process of essentially of the clavicle and the lateral end of the clavicle, of the scapula, and the lateral end of the clavicle. It's fibrocartilaginous articular disc within this joint cavity, and the joint capsule is strengthened by the acromioclavicular ligament, and the clavicle is bound to the coracoid process by the coracoclavicular ligament. If torn, the acromion and the clavicle no longer align, you get shoulder separation. Now, the glenohumeral joint is the most common joint people think of, the ball and socket joint, when they think of their shoulder joint. It's the most mobile of all joints, of the synovial joints and joints in general. It's formed by the head of the humerus and the glenoid cavity of the scapula, or basically the glenoid fossa of the scapula, a little opening at the lower, slightly inferior to the acromion process of that scapula. And it permits the greatest range of motion of any joint in the body. It's the most unstable, though. The more mobile, the less stable. And it's the most frequently dislocated. And also, a lot of injuries occur here. The more mobile something is, a lot of injuries tend to occur there from not having proper stability, proper strengthening on top of the mobility, or to join with the mobility. Got to have a balance of both. Fibrocartilaginous glenoid labrum encircles this socket, and there's an abundant bursae, where it decreases friction, where the tendons and muscles extend across the capsule. It's a primary job of bursae. And there are also supporting ligaments and tendons there. We're not going to go into the great detail of the ligaments at this time here, but that biceps brachii tendon plays a great role in that anterior portion there of that shoulder, that glenohumeral joint. Yeah, people often get pain there, that tendon, that biceps tendon. Now, there's most joint stability is due to the rotator cuff muscle imbalances to some extent. The subscapularis, which is technically an internal rotator or medial rotator, and you have a supraspinatus, which is more of an abductor of your shoulder, and the infraspinatus and teres minor are more of your lateral or external rotators. You don't have to know that now, but in muscles, we'll talk about that a little bit more. They work as a group to maintain stability. As a whole, those muscles combined, SITS, S-I-T-S, right? Those four muscles together, they stabilize the shoulder. For now, let's take a quick look here. We're not going to spend too much time with this at the moment here, but here you have a acromioclavicular ligament with the clavicle and the acromion process, right? Making a connection there, the scapula, the clavicle there, and here the acromion process here, the scapula coming across here. And then you have behind, which are kind of hidden a little bit here. And the coracoid process here, and the glenoid fossa would be right in here. We just have this all between or underneath all these glenohumeral ligaments here. A lot of ligaments to support the stability of that shoulder. And actually, for now, that's all we're going to spend time with. As far as lateral view in the coronal section of the shoulder, take a quick look here. So here we have that tendon of the long head of the biceps brachii, right here, and that's an oft injured or strained type tendon there. And that bursa sac can get damaged and create a significant amount of pain if that fluid leaks out, if there's too much compression is actually created there at that disc, or at that bursa, I should say. And here in this picture here, you should be able to recognize the AC joint, then the acromioclavicular joint, the clavicle here, and the acromion process, the scapula here, and then the tendon of the long head, the biceps brachii here, that bursa. This being a deltoid muscle technically here, attachment there, and supraspinatus muscle here with the supraspinatus tendon. There's our synovial membrane on top of that hyaline cartilage, that articular cartilage, right? And then of course this being the humerus, basically the metaphysis coming up into here, and the epiphysis at the top here. And the shoulder joint dislocations are common due to joint instability. Shoulder separation refers to acromioclavicular dislocation, or AC dislocation, when we have shoulder separation. There's a pain when the arm is abducted more than 90 degrees, is actually not called shoulder separation, and we're basically talking about something different when you bring your arm out to past 90 degrees into abduction. Under load, there is a risk of shoulder impingement. Actually, not technically shoulder separation. It's actually called shoulder impingement, whereby there's a potential for injury while we don't want someone to lift significant loads above about 90 degrees of abduction away from the body. The glenohumeral joint dislocates when the humerus is fully abducted and struck hard, forcing it into more abduction than it's capable of achieving. And then the shoulder appears flattened and squared off. That humeral head is anterior and inferior to the glenohumeral joint capsule. The elbow joint is a hinge joint composed of two articulations, the humeral ulnar joint and the humeral radial joint. And that said, they're both enclosed in a single articular capsule. And for our elbow here, we're talking about the basic actions of flexion extension. It works like basically like a single plane of motion generally. It has some slight variable motion otherwise, but it's extremely limited. It's basically a hinge joint. And here be our humerus, and there's the ulna, the radius here, and there's the tendon of the biceps brachii, cut right through there. We have our articular capsule in here. And of course, the lateral epicondyle of that humerus and medial epicondyle of the humerus, a lot of ligaments to help keep that elbow joint stable. Without that, they're going to create some great instability and pain. I'm not going to worry about the sagittal view at this moment. That said, the elbow is very stable because the articular capsule is very thick. And the bony surfaces, the humerus and the ulna interlock very closely, and a lot of ligaments, of course, holding it in place as well. And we don't have to worry about those ligaments at this time. Subluxation refers to incomplete dislocation at the head of the radius, and we're basically talking about the head of the humerus is pulled out of its annular ligament, and it occurs, the radius is pulled out of its annular ligament, and it occurs almost exclusively in children. You don't see that subluxation there in the forearm like that, except for those typically under 5 years old with some extreme trauma. And that said, that ligament is thin, which is also why it happens for children, not really adults. It tends to be a lot thicker for the adults. And the radial head's not fully formed, which plays a role as well. The doctor may actually maneuver the radial head back into the annular ligament if necessary. The hip joint is the articulation between the head of the femur and the acetabulum and the os coxa. Acetabular labrum is a fibrocartilaginous ring that deepens a socket. It's more stable and less mobile than the glenohumeral joint, but I think we're going to come back to that in our next video, so I'll make this one too long for you, so we'll stop at this point and come back with the hip in just a moment for the rest of section 9.7.